Welcome. Thank you for standing by. At this time, all parties are in listen-only mode until the question and answer session at the end of today's conference call. At that time, you may press star 1 to ask a question over the phone. Today's conference call is being recorded. If you have any objections, you may disconnect at this time. I would now like to turn the call over to Carrie Hurd. Thank you. You begin, ma'am.
Thank you. Good afternoon, and thank you for everyone joining our HHS Region 6 Trouble Opioid and Substance Use Disorder Demo webinar. My name is Commander Carrie Hurd. I'm the Region 6 Region Administrator for SAMHSA. I represent the states of Oklahoma, New Mexico, Louisiana, Arkansas, and Texas. The purpose and focus of today's webinar is to support tribes in Region 6 in locating and selecting data from public sources related to opioid misuse and other substance use disorders. Hopes are that tribes will gain an understanding of available resources and opportunities for technical assistance related to data collection, hopefully to improve surveillance capability and also to assist tribes in increasing their ability to be competitive for future funding opportunities. So today we have a really awesome lineup of presenters that are going to share with you both opportunities for federal, state, and community level data, as well as some tribal parts that are going to share some of their work as well. So as we go along, I'll introduce each presenter and they will share their information. So I wanted to share a document that is available that provides federal data resources and some opportunities for technical assistance. The tool that I'm sharing here, it represents 16 key data sources for prescription opioids and heroin. So as you go to this link and look at this tool, you'll see a brief description of data source, a list of prescription opioids and heroin-related indicators that's included in this particular data set. Availability of online data analysis tools that allows the users to generate own indicator estimates, for example, prevalence or trends, or subgroups like age, gender, state, and whether you can download raw data and also data limitations. So included in these data sets would be Center for Disease Control and Prevention Multiple of Causes Death, which is known as CDC Wonder, SAMHSA's Treatment Episode Data Set, known as TED, also Federal Bureau of Investigation Uniform Crime Reporting that you might find useful, Bureau of Justice Assistance Prescription Drug Monitoring Program data, also some data from Center for Medicaid and Medicare, our National Survey of Drug Use and Health, and then also CDC's Control and Prevention Youth Risk Behavior Surveillance System. So I think you may find some of this data helpful as you're looking at strategic planning and grant writing. And I wanted to share with you an opportunity that SAMHSA has for technical assistance around opioids. So using the link that's provided in this slide, you can request technical assistance from SAMHSA related to opioids. So there's a really unique opportunity to be able to reach out and request assistance in a broad array of areas related to opioids. And I just wanted to touch on the Tribal Opioid Response Grant that is currently available for applications, with applications closing on August 20th. Through this link, you can check out the funding announcement. This program aims to address the opioid crisis in tribal nations by increasing access to culturally appropriate and evidence-based treatment, including medication-assisted treatment, one of the 3 FDA-approved medications. So the intent is to meet unmet needs for not only prevention, but treatment and recovery services. Also, by visiting this link, you'll be able to see opportunities for webinars for technical assistance. We'll provide information on how to submit this grant, and then hopefully announcements for a more programmatic webinar that's a possibility to talk more about strategic planning for apply for this grant. So I would encourage you to go there and take a look. My information is also available at the end of this webinar, so you could also reach out to me and I could provide help as well. So I want to move on to Captain John Maroney. He is the Region 9 Regional Administrator, and he's going to share some opportunities available from the Health Resources and Services Administration. So go ahead, Captain Maroney.
Thank you very much. May I just ask, Carrie, you'll be advancing the slides, is that correct?
Yes, I will advance the slides.
Perfect, perfect, thank you. So good afternoon, everyone. I'm happy to be with you here today to share a few words about HRSA programs and HRSA's response to the opioid crisis. I'm pinch hitting for my friend and colleague, Dr. Princess Jackson, who passed away last month and was the regional administrator for HRSA Region 6. And Captain Martha Culver will be serving as acting regional administrator, and I have her contact information on my last slide. Should be any questions or follow-up needs that arise following the webinar. So next slide, please. So I'm got a coordinate here. Let's see. Okay, so HRSA supports more than 90 different programs that provide health care to people who are geographically isolated, economically or medically challenged through, or who are medically challenged through grants, cooperative agreements with community and faith-based organizations, colleges, universities, hospitals, state, local, and tribal governments, and private entities. More than 3,000 awardees, HRSA programs serve 10 to millions of people. Next slide, please. Touch briefly on some of HRSA's major programs. The largest is the Center program, which supports access to affordable, accessible primary care for nearly 26 million people at more than 10,000 delivery sites. The White program makes grants to cities, states, and local community-based organizations to provide HIV care and treatment services to low-income people living with HIV. Next, the maternal and child health block grants to all states and jurisdictions supports women's and children's health across the life course. And then the maternal, infant, early childhood home visiting program supports voluntary, evidence-based home visiting services for at-risk women and parents with young children up to the age of kindergarten entry. Next slide, please. Our Office of Rural Health Policy supports rural health programs, including rural health networks, Black lung clinics, telehealth, and Veterans Rural Health Access programs. Our Systems Bureau supports organ transplantation, 340B drug pricing program, as well as poison control centers. Next slide, please. The National Health Service Corps scholarship and loan payment programs in exchange for service in high-need areas by primary care providers, including physicians, dentists, physician assistants, nurse practitioners, the health providers, and other primary care providers and health profession students are supported or is supported by HRSA, as well as the Nurse Corps and state loan repayments. And I understand Commander Gualan from Region 6 is on the line and will be following my remarks with a few words about a special initiative through the National Health Service Corps. So as I wrap up on just this very high-level, light-touch overview of her many different activities, I wanted to show on some of our opioid-focused activities in the past few years. So we've made resources available for expansion and integration of mental health and substance use disorder at community health center sites. We've made resources available for health interventions and substance abuse treatment. There are more than 150 community health centers nationwide that are participating in Project ECHO, or Extension for Community Health Outcomes, and a confidential peer-to-peer telephone consultation service focusing on substance abuse evaluation and management for primary care clinicians in health centers is also been made available in recent years through HRSA resources. And we've also made grants to expand access to naloxone to reduce overdose deaths in rural communities. We have an open opportunity right now. The deadline is the 5th, which was 2 weeks from yesterday, and it's the community's opioid response program plan. These are active links in my presentation, and I'm hoping these will be available to the participants at the conclusion of the webinar. So we do anticipate future funding opportunities for opioid and substance abuse targeted grants, and more about these opportunities and about HRSA's and HHS's opioid resources can be found at the web pages listed on this slide. And again, I hope that's going to be available for everyone. And then finally, this is a slide I wanted to include. If there are folks from Region 6 that have follow-up questions that surface after the webinar, Captain Martha Culver will be the appropriate person to reach out to at that time. I'm going to be on the line for the whole webinar should specific questions arise. So with that, I think I need to turn the microphone over to Commander Galandi.
Mr. Maroney. My name is Commander Tracy Galandi, and I'm the Oklahoma State Lead for the Dallas Regional Office National Health Service Corps program. And I just wanted to extend a little bit on Captain Maroney's presentation just to let the tribal sites know about our exciting National Service Corps Substance Use Disorder Expansion project to increase our workforce. In fiscal year 2018, the Consolidated Appropriations Act allocated $105 million to expand the National Health Service Corps, and at the time we are actually processing sites to opt into our funding opportunity. The National Health Service Corps expanded substance use disorder program will provide $75,000 in loan repayment program to extend a 3-year service at an evidence-based substance disorder approved site, which does include our IHS and ITU tribal sites that are located in HRSAs. However, the sites will need to opt in to be included in this funding opportunity. Applicants bring at an NHSC approved substance use disorder sites will apply, and they can utilize either the mental health or the primary care health professional shortage area score, whichever is higher. Our substance use disorder providers that will be eligible will be physicians, nurse practitioners, physician assistants that administer MAT therapy, which is our medication-assisted treatment therapy. Also, they're adding a new category of grantees, which is our master's-trained substance use disorder counselors. The facility that will be eligible for this opt-in will be our outpatient substance use disorder facilities and or our office-based outpatient medication-assisted treatment programs. Existing or auto-approved tribal sites will need to opt in. You will need to contact an analyst to opt in for this facility, for your facility to be included in this opportunity. You can submit an inquiry via the BHW program portal. Utilize your National Health Service Corps point of contact to submit that inquiry. And new sites will need to opt into their regional analyst by August the 14th. They will have another loan repayment cycle that will open up in the fall of 2018. I just want to let you know to contact Tracy Galandi, that's TGUALANDI, at HRSA.gov for Oklahoma. And also the contact for New Mexico will be Joey Carter, jcarter2 at HRSA.gov, or you can send Martha Culver her contact information on the screen, and she can send an email to us if you need further information. Thank you, Carrie.
Oh, thanks so much for sharing, and we'll try to get those slides when we share the slides with the participants. So thank you so much for sharing about that important program. Next up, we have Lisa Neal from Indian Health Service, Public Health Advisor. Go ahead, Lisa.
This is Lisa Neal from the Indian Health Service. I'm mainly interested in being sure that everyone is aware that we do have the HOPE Committee here at Indian Health Service, and that there is the Tribal Epidemiology Centers program that I help manage for the agency, and the website for that is Tribal Epi Centers. Make sure I get that right. .org. There's a lot of information on there about these specific organizations and the resources they can be both tribes and to area offices. Thank you.
Thank you, Lisa, for sharing. And also attached to this slide is the link for the HHS Hope Committee, so participants can find out more about that committee. So next, we're just really excited to have the Albuquerque area Southwest Tribal Epicenter with us on the call. And Kevin English is going to speak about some data that may be available through the Epicenter. So, Kevin.
Oh, Carrie. Hi, everybody. So as Carrie mentioned, my name is Kevin English, and I'm the director of one of 12 tribal epicenters across the country. I'll hear from at least one more on this call. If we can go to the next slide, things that I'd like to share with participants on the phone, some of the different data sources that we do have access to and that we can provide technical support and technical assistance to tribes and tribal organizations interested in applying for this or other grant opportunities related to opioids. If you left-hand column, we typically look to you all as tribal partners to identify any existing data sources that you may already have or that you're collecting in your community. When we're talking about opioids, that could be through any surveys that you've conducted in the community. It could be through your EHR systems, electronic health records, whether it's HHS, tribal sites, or potentially even through behavioral health programs. I want to look at EMTs and fire departments to see who's collecting what when it comes to overdose and naloxone distribution, and looking at law enforcement records. Some of the sites that we're aware of that are collecting data locally at the tribal level. Then know that there are other sources out there that we can access. Carrie mentioned some of them in the beginning of the call. We can look to state departments of health for vital records, for data such as mortality data related to overdose, natal abstinence syndrome. We can look to hospitalization, inpatient discharge data systems, emergency department data systems, and then also, of course, public health surveillance systems, adult and youth, which we use acronyms BRFIS and YRS, and the Indian Health Service as well. If you look at the right-hand column, you can see some of the ways that we provide technical support with these different data sources. We can assist tribal communities in collecting their own data, whether it's through quantitative or qualitative methods like surveys or focus groups. We can analyze your existing data and figure out how best to report it, including in grant applications. Develop databases for your programs that can be utilized to track information over time. We can certainly work with you to collect some of the secondary data that's already out there at different entities like state departments of health, IHS, and CDC. And we can assist in developing evaluation plans and helping provide technical support for your evaluation. If we go to the slide, quick, we have a bunch of different data slides here to share with you. I don't have time to go through them all, but I just wanted to give you a taste of some of the data that we can access from different sources. Let's go ahead and go to the next one, Carrie. So look at national data that's coming out of CDC. We can help you run queries in the CDC Wonder system, which will, in this case, it shows, if you look at the dark blue line, the American Indian Alaska Native rate of overdose across all opioids, across a 15-year period. So you go to next. Here you specifically for heroin. Again, it's still the blue line, and this is national data. If we go to next, here's synthetics, and this is where we're seeing the rise of fentanyl in recent years. And you see that sharp upward slope happening around 2015. It's happening for the American Indian Alaska Native population as well. Let's keep going. Here, age groups that's most impacted by overdose deaths among the American Indian population nationally, and you can see it sort of beginning around age 25 and starts to trail back off around age 54 for any opioid as well as heroin use. Go to the next slide. You see by sex or gender here, you can see that the overdose death rate for American Indians is greater among American Indian males compared to females. Go to the next. Then look at state differences too. So I know there are several states in Region 6. I tried to pull your data from all states. Fortunately for Texas, Louisiana, and Arkansas, the data is suppressed due to small numbers. But here you can see the overdose death rate among non-Hispanic American Indian Alaska Natives. Oklahoma and Colorado both exceeding the national rate, and New Mexico and Arizona under that. If we go to the next. Here, New Mexico specific data, you can see even though we have a lower rate than the national average, unfortunately we're seeing a very exponential rise, which is of concern. want to look at the county level. So now we're going within the state. So we started with federal data, now we're looking at state data, and now even moving into county data. And you see the great variation by county, and these are the counties with the largest American Indian and Alaska Native population in New Mexico. If you go to the next. You can neonatal abstinence syndrome. This isn't just for opioids, but you can see this steady rise, and that, in fact, must be caused by opioids because we don't know of any other substances that have come to play such a driving role in these data trends. The next. And again, our state, we do realize if you look to the far right, American Indian and Alaska Native rates of neonatal abstinence syndrome still remain low. Go slide. This is sort of the final group of data coming through. So then you want to look at your adolescent trends as well. And one of the things that we do at our tribal epicenter is we oversample schools, high schools and middle schools with high American Indian student enrollment so that we generate not only state and county level estimates of various health risk behaviors, but in many cases tribe-specific estimates. So if you're alone and you're from one of the 27 tribes in the Indian Health Service Albuquerque area, please contact me because we may have this data specific for your tribal area. You see here we show that the prescription painkiller use, around 11% of high school students that are Native American in New Mexico are current users. Heroin is much smaller number, 2%. If you go to the next slide, school. It can be as high as 19% in some schools and as low as 2% for the current painkiller use. Next. We also see that the current painkiller use by male, female, it's very similar trends across the statewide population and the American Indian Alaska Native population. Interestingly, though, there's slightly more American Indian females that are current painkiller users. And then this one's troubling. So we know that nationally we're seeing a trend away from opioid prescription use and towards heroin. And what we see among our population here in New Mexico is among those adolescents who have ever used prescription drugs, the rate of current heroin users goes up substantially. In the population, it's only 2% using heroin, but among those American Indian Alaska Native students who have ever used prescription drugs, it's almost 10% that are currently using heroin. And among those with current painkiller use, it's almost a quarter are currently using heroin. So they're co-occurring. I have a fact sheet that we developed that you can access through our website, which is on the next slide. And up to the top tab, it says Reports and Pubs. If you click on there, you can find the opioid that I just mentioned. And it sounds like Carrie will be distributing the slides. I know I went through them extremely quickly, but I want to respect everybody else's time. In the next slide, I think that's just the contact information for me. Thank you so much.
Well, thank you so much, Ken. I really appreciate you putting work that you did into this presentation. I appreciate the information that you shared. Next up, we have Tyler Daugherty from the Oklahoma Area Tribal Epidemiology Center. Tyler, go ahead.
I'm just going to briefly talk about one of the data sets that we used for the injury list that we were charged with making, detailing the distribution among Native Americans in the state of Oklahoma. Next slide, please. This data is the hospital discharge data that we were granted access to and now able to house at the Oklahoma Epidemiology Center. So this data set has about 9 million individual rows, 9.5 million individual rows of data with nearly about 200 columns of data. So there are all kinds of demographic data, age group, race, marital status, also a zip code, so we can drill it down to tribal residents that were hospitalized from that reside within a certain tribal jurisdiction. Contains up to 15 ICD-9, ICD-10 codes, so you can look at comorbidities or causes for hospitalization, as well as some other issues going on with co-occurring with the hospitalization. It will have a primary diagnosis, also subsequent ICD-9 or 10 codes, depending on the year in which you query. It also has E-codes for injuries. Those are what the Oklahoma Tribal Epicenter used to create its Atlas data and data visualizations. It also has the length of stay data, estimated cost, and goes on. There are quite a few variables in this set and allow for a lot of different levels of stratification. So if you are a tribal community within Oklahoma, we have this data most likely for your tribal jurisdiction. Next slide, please. Yeah, you are more than welcome to contact the Oklahoma Area Tribal Epicenter for any sort of technical assistance requests, data requests, tribal organization or urban Indian clinic assistance request will be honored. Next slide, please. Tribal hospitals do not have to report to the Oklahoma State Department of Health where this data set comes from. There can be gaps. That is a limitation of this data set. Only state accredited hospitals have to report to this database. So there will be gaps. Some Native hospitals do report to the Oklahoma State Department of Health, but some do not. So just be aware that there could be an underrepresentation. Also, this data set will contain racial misclassification. Currently, the Oklahoma State Department of Health has not allowed us to link hospital discharge data with IHS patient records, IHS patient databases, catch any racial misclassification. So the estimates produced from this data set will also be underestimated. Another unfortunate limitation of the data. And I'm ahead of myself. And next slide, please.
Okay, next slide. Here we go.
Here is my contact information. If you guys have any questions, please email me. I'll get back with you as quickly as possible. And something I forgot to add, looked at, so there's different drug-related hospitalization codes, and so due to some of our other grants working with opiates, I went ahead and scrubbed that data set for all opioid-associated hospitalization and the comorbidities that were happening with that hospitalization. So it shouldn't take too long to process your technical assistance request surrounding opiates because the data set's already been mined for those. So, but if you have any additional questions or comments for me, please feel free to reach out.
Thank you so much, and thank you for that technical assistance that you're going to be bringing to the tribe. So next up, we have Brooke Doman. Brooke is the tribal epidemiologist for New Mexico Department of Health. So Brooke, welcome. Go ahead.
Thank you. I'm glad to be here today. Again, my name is Brooke Doman, and I'm the tribal epidemiologist for New Mexico Department of Health. And one of my main duties is to help tribal communities and tribal organizations and all of the American Indian population in New Mexico get their health data. So please reach out to me. It's my job. I'm always there to help out. Next slide. In New Mexico, I kind of look at our American Indian sources of health data in two different ways. First of all, we have the larger American Indian Alaska Native population, and then we have our tribal populations. And for the first one, our larger New Mexico American Indian population, Kevin English touched on this a little bit, but we do have mortality data. And within our mortality data, New Mexico is a little unique in that we collect tribal affiliation. And we also have hospital inpatient discharge data. That also contains IHS data as well. There is also tribal affiliation in our HID data. I can't really say how good that is, but it is something that we do have in our data. And just to go back to the more data, we also can get down to the type of drug overdose, so opioid, meth. Usually it's multiple, not just one. And then switching, for regards to tribe-specific data, we do have a few tribe-specific data sets that are available. Those include mortality, birth, and death. Next. And so we also have to make a caveat. There has been a big opioid crisis in New Mexico, but fortunately that hasn't really been seen in our American Indian communities. But like Kevin mentioned, it is increasing. So I do like to try to, when I'm looking at opioids, not just include opioids, but the larger substance abuse picture, such as meth, alcohol. Some of those are also issues. And so how do you get the data? There's a couple of ways you can go about getting the data. New Mexico has a portal for disseminating all its health data. It's got the lovely name of IBIS, which stands for Indicator-Based Information System, which is kind of a complex-sounding name. But if you go there, there's tons of information. It can be a little overwhelming. But that's our main way of getting data out to our constituents. Also, it seems too overwhelming. That again, it's my job to provide health data to our American Indian communities. So, like, give me a call or a data request. Next slide. And so to dive in a little bit about IBIS, just to show you, if you're interested in just quickly looking at some data, we have data sets that are available. And if online, you can see there's a column for Explore data sets, and you can see all the data that's available. And some of them that you might be interested, I mentioned death data, some surveys, the YRRS, and hospital inpatient data. Next. For our tribe-specific, we keep that secure, so it's not open, public-facing, so nobody can go in and just look up any tribe-specific data. Consider that PI. But if you do want to have access to your own tribe's data, you can contact me, and we can work on getting you access to your tribal data, which resides on the website, but it's under, there's a password protected. And you can see, again, I highlighted, this is what the page would look like, and we have the 3 data sets, again, the death, birth, and population data sets. Next. And if it seems too complicated, please just give me a call. I can talk about what data is available and what we can do to help out. So, and there you go. I'm going to drop off the call, but please feel free to reach out to me.
Thank you so much, Brooke, and I appreciate your willingness to present today, so thank you very much.
Thank you.
Our next speaker is Scott Schaefer. So Scott is from the Oklahoma Center for Poison and Drug Information, and I want to take the opportunity to welcome Scott to the call. Scott, you go ahead.
Yes, thank you very much. And in particular, I'd like to thank Captain Patrick Young, who I don't believe is on the call. We are a type of resource as far as data. It may be helpful for all of you. A little bit of background on poison centers, people tend not to think of us as a source of data, but we're continually collecting data 24 hours a day, 7 days a week. And I think one of the big selling points for poison center data is that it's near real time. If you ask me right now, how many opioid exposures have you had this week, I could tell you to within 7 minutes by querying our data. Next slide. As is real time, our data represents every poison center. It's a toll-free number, should be accessible to anyone within the state. The number that we have, and it's up in the upper left-hand corner, is 800-222-1222. Any call in the United States, that number, you'll get the poison center that serves your state. It could be multiple states, or it could be just a portion of a state, depending on a lot of different things, population demographics, languages that are spoken, population densities, and so forth. Calls from medical professionals, so the intensivist that's caring for a poison patient in an ICU, the emergency department physician who gets a poison patient who comes in, and nurses are helping care for them as well. It's, in Oklahoma at least, that's about 25% of our calls, as about 75% of the calls from members of the public, so the caregiver, mom, dad, babysitter, next door neighbor. Answering phones in a poison control center are medical professionals, so there could be pharmacists, nurses, physicians. They go through a very rigorous training process to know how to deal with a poisoned patient or to treat an acutely ill or a critical poisoned patient. But also a substantial portion of that training is with coding the information as it comes in. And mentioned in real time, as soon as that information is starting to be entered into the workstation that the specialist is working at, it gets uploaded to the national database. Next slide. Database, it's referred to as NPDS, that stands for National Poison Data System. It's a set of the information that's collected on the state or the poison center level. So before the information gets uploaded, it's stripped automatically of all PHI, and additionally, it's just a subset of the information that we collect. So, for example, one thing I'm aware of, I know that does not get uploaded, is the causal relationship to the patient. That's something that we collect on every call, and various other things that did not get uploaded and never make it to the National Poison Data System. The thing that is not uploaded is the narrative section. So, in addition to all these data fields that are collected in the center's database, the narrative section, basically it would be like the notes section in a chart, a patient chart. So, in order to protect confidentiality, because our specialists very frequently will collect such as the nurse's name, what room they're in, what healthcare facility they're in, rather than risk that being included into a national database, that information is just not uploaded at all. The data collected is fairly granular. We get quite a bit on patient demographics, where they're located, both by county and zip code, what sense or substances the person exposed to, any treatments, patient either the poison specialist recommended that were taken at the healthcare facility or at home, and clinical effects. So did the patient have decreased respiratory rate? Did they have hypotension? Any type of symptoms that the patient developed. And the special also code whether or not professional opinion it was related to the exposure. So if somebody comes in and they're very agitated, have a rapid heart rate and elevated blood pressure, and it's an opioid overdose, then the specialist will code is not related to the exposure. And ultimately, what outcome? Was it a minor effect, a moderate effect, or a major effect, or unfortunately, very often we see fatalities with the opioids. And was the patient to an intensive care unit, to say a medical surgical floor in a hospital, or were they discharged from the hospital or from the emergency department, or they managed at home? Next slide, please. So we can get a fairly granular picture of what happened with the patient, what they were exposed to. The substance data, what they were exposed to, can be broken down as well. So it's not just opioids that we look at. We can look at specific opioids. Did they get hydrocodone, oxycodone, tramadol, buprenorphine? Was it combined with any other medications? And that way we can also look at a specific combination of medications becoming popular in this, on the streets, or is it that particular combination more dangerous than either medications taken together? So we can break it down fairly well. And again, our specialists are trained very well in how to extract as much information they can about the specific product. Very often they can even get it down to what manufacturer of who was the manufacturer of the particular drug that the patient took. Slide. The quiz on this at the end. No, this is just an example of a report that I could run just pulling from our database, and at exposures in Comanche, Oklahoma for 2017. So if you look on the left, we've got all the potential reasons for exposure, or at least the reasons that we collect, and it's against age groups. It's very easily exported to Excel, so this is what it ends up looking like. Break it down by age groups, and again, the reasons on the left-hand side. So now we have it in a spreadsheet, we can very easily manipulate the data. Next. In 2018, general, we consider to be the bar on the left, generally consider that to be a pediatric exposure. I try to know better than to get into something, and we cut off about 5 years old, make it a general. Maybe somebody has Alzheimer's and didn't know what they were doing. Well, we would call that also a general type of exposure. Therapeutic versus, as you can see, are fairly large, or worse than trying to hurt themselves. Misuse would be a category where a person knew better than not to take it. So in opioids, it might be somebody who has severe pain and is taking more than the doctor prescribed. They know, and again, it goes back to they knew better than not to. And abuse, it's surprising, actually, in the years that abuse was a lower quantity. If a person's taking medication or the drug for abuse purposes, they're looking for the psychiatric, the neurologic effects that get high. Next slide. Again, down by age groups. This is surprising to me as well that the largest amount of exposures were age group 50 to 59. Now with this, we might collect data on race or ethnicity. It potentially useful to the people on the call would be looking at maybe the percentage of Native Americans that are present in a given zip code or a given county, and using this to somewhat extrapolate what percentage of Native Americans might have been exposed. It's just one more way to look at the data. Now, there are some downsides to data. I'll be honest with it. with everybody there. It's not comprehensive. We are not a mandatory reporting agency. So ours is just maybe a snapshot of the true number of exposures out there. And I think, get on my soapbox a bit, I think both state and national people are missing the big picture. For example, poison data very rarely gets incorporated into some of the larger databases. Examiner data. We're missing a lot of cases. I'd be willing to bet if somebody who's, say, 55, 60, 65 years old presents at the medical examiner, it's going to be fairly likely that they're going to do a toxicology screen to out those patients, those older patients who have overdosed and died. One that we have is, as I said at the beginning, that I bet are the most current of all databases that are available. Again, minutes or so is going to be some of the oldest data that we have. We're looking at federal data. You're looking at 2 to 3 years before it gets massaged and published. I don't have a contact information slide, but you can call the toll-free number 800-222-1222. If you're in Oklahoma, you can get directly to me. Thanks for the call. Or if you get in another state, or if your cell phone was issued in another state, then they can transfer you to Oklahoma without any problems. Thanks for inviting us.
No, so much, Scott, for being willing to step in on such short notice and share the work you're doing. I really appreciate it. So next we have Dr. Greenfield from the University of Minnesota Medical School, Duluth campus. She's going to share some of the work in Minnesota and talking about how it might apply to some future work for Region 6. So go ahead, Dr. Greenfield. Thank you.
Thank you very much, and good afternoon, everyone. I'm really glad to be here with you. And I've been up in Minnesota for about 3 years now. It's where I'm from originally, but I did my graduate training 7 years in Albuquerque at the University of New Mexico, working with Kamala Venner. Next slide, please. So you might know why someone from Minnesota is speaking today, since I'm in a different region. And the way I got involved is because about the last 6 months I've been on a project to gather all of the opioid-related data for the state of Minnesota for American Indians. Because in November of last year, myself and Melissa Walls, another researcher in Duluth, who was on addiction treatment and use with American Indian communities, emailed by Kathy Epps from the National Institute on Drug Abuse, and she sent us this graph. She said, "It is happening in Minnesota. What's going on here?" And you can see that there's a huge gap and a higher rate of overdose for American Indians in our state. Very concerning, the biggest gap in the country that we know of. And she said, could you do something to look into this, try and figure what's going on in a quick fashion? Next, please. So she is a coordinating center from the National Institute on Drug Abuse called NDUS, the National Drug Early Warning System, and they're based out of the University of Maryland, and they do hotspot studies. They did one with New Hampshire, and now we're working with them in Minnesota for another study to look at new and emerging drug trends and try and quickly understand what is happening and figure out ways that there can be public health and other interventions. So we've been gathering Minnesota data from national, state, tribal, many different levels to try and see what's available to try and understand and reduce the disparity in opioid overdose deaths for our state. And the NDUS website has a lot of different resources, so I'd encourage you to take a look at their website as well. And so what actually today is just providing an overview of what this process has been like, because it's been a new process for me finding and looking at the opioid data in Minnesota. And then also some tips about places you might look for data that you might not have thought of before. Next slide. to give you the takeaways at the beginning of what this process has felt like on our end. First of all, we've heard a little bit today already, there's always going to be gaps in the data and misclassifications. There is at least some data that you'll be able to find that will help you answer the questions that are important to your tribe. Also, because this is a new and emerging issue, the opioid crisis, and a lot of new resources have been dedicated to data collection recently. There are new sources for finding information that are developing all the time. So CDC is doing a lot of new initiatives to try and gather more real-time data about non-fatal opioid overdoses. And if you take a look at their website, there are some pieces there. There are people who can help. You've already heard from a lot of them today. There are many people who spend their entire day looking at the data, getting familiar with the data, and a good place to start is just finding those people in your state, in your communities, who can help you understand and connect with the data. And really just a reminder that the goal of data, the reason we collect data is because we're trying to improve people's health and well-being, and the data just help us be more specific in our efforts. Next slide. So this is one way that I felt and others may have felt as you're trying to collect data that can inform grants, treatment efforts, different things like that. Sometimes it feels like there's no data that can help you get funding or to address the issues that are important to your communities. On the other hand, on the next slide, it can sometimes feel, I definitely felt this way in working with the Minnesota project that we're doing. There are so many different levels and layers and groups that are collecting data, and it can be hard to know where to start. But if you choose a specific piece of the issue that you want to work on, say office-based buprenorphine or increasing naloxone access, once you have that target in mind, then you can be more specific about what data that you're choosing to look at. So in the have remaining, I just want to point out a few sources that we found in Minnesota that were particularly useful. The first here, looking over time, especially with opioids, is a really useful strategy. And you can see here that this is a graph of transmissions in Minnesota. This is state data from 95 to 2016. And the solid line represents American Indians in Minnesota. The red line represents all races combined. And what the lines represent is what percent of admissions for a particular substance there were in each year. So the gray line at the top, there's been this rapid decline, well, 20 years, in alcohol admissions, particularly for Native Americans in Minnesota. So the solid gray line, it's gone from 70% treatment admissions were for alcohol in 95, and now in 2016 it was about 20%. And then when you look at opioids, which is represented by the orange line, you can 95 we had about 0% admissions that were for opioids. But that's been slowly increasing over time, and it's been increasing more quickly for Native Americans in Minnesota, so that in 2016, actually in 2014, the admissions for opioids eclipsed and were higher than the admissions for alcohol. And as a treatment system, as a community, we need to figure out ways to respond to that and best provide treatment for people who are coming in with different primary substances. Next slide. The source I want to point out is from our Minnesota Department of Health. And our Department of Health has really been committed to finding and collating data for the opioid crisis. And you can see different categories of things that you might look at to consider how your community and your state are doing in terms of opioid indicators. And the link for this is at the bottom. I won't go into it too much here, but you can click on all of these items and see where the data sources were from. Some of them are from national sources. Next slide. And the RDP recently released this report about the disparity in opioid overdose death rate. It's about times higher for African Americans and 5 to 6 times higher for Native Americans in Minnesota, and they've did a really great overview of the things that might be contributing to this using a racial equity lens and also including some data about the issue. And the Department of Health in Minnesota said if anyone has questions, they'd be happy to help you with data and think about sources you might consider. Next slide. I want to add a few other ideas of data you might consider that can inform what you're doing. So naloxone distribution, often data is collected by the groups that do that distribution. Where need for naloxone, who is getting naloxone, where is it being used. Needle exchange programs have a lot of useful data. Think about the system of care for individuals with opioid use disorder that's available in your community. Where do people go? How well linked are the different programs? Where do people drop off? And what type of care is provided? Is it abstinence-based, medication-assisted treatment? And create a map like that can provide ideas about where you might want to make some changes. Also thinking about the number of people who are in recovery from opioid use disorder in your community. I don't think we collect enough information or have a sense of how many people are in recovery, how they can be a part of the system of care, because many people in recovery want to give back to people who are currently. Also appropriate the availability of traditional healing. And then finally, the last one, being a university-based researcher and not long ago a graduate student, universities often are really willing to help out if you have needs in terms of data analysis or looking for data sources. Graduate students are often very eager and willing to help communities. And then, of course, being careful about data sovereignty and agreements like that. But it's one place that you could consider just writing to a department and seeing if anyone would want to help with projects. Next slide. And there, I hope that I've given you some ideas as you start down this path. My contact information is here. I'm happy to answer any questions about what we're doing in Minnesota. I also want to thank the individuals and groups in Minnesota that have been a part of this process, especially Kathy Etzet-Nida as well for getting us started down this road. Thank you.
Thank you. Well, thank you so much for being with us on short notice. And I appreciate so much your help and your offer of support. So thank you very much. I'm going to ask if Joni Lyon is on the line, and if she is, if she can hit *0 so our operator can connect her.
Can you hear me?
I am. Welcome.
Welcome. I did it right.
I'm glad you did too. Welcome. So Joni is from the Cherokee Nation Behavioral Health System. She's the clinical administrator, and she, along with Sam Breshaw, who's a project director with the Cherokee Nation Behavioral Health, are going to speak to the Cherokee Nation's experience. And they've been doing some wonderful work, and I very much appreciate you coming on today. I'll leave it to you.
Okay. I'll start off by, like I said, I want to just do a quick overview of what our previous and current experiences are with providing MAT services. And I'll say that I know our clinic director, Mark Taylor, is on the call. I don't know if he's able to speak, but he's definitely on the call well. And then Sam is our prevention supervisor. So he heads all of our community work with our prevention programs that have been vital in collecting our data sets for our community, because we know the challenging times of, since the Oklahoma tribes are not reservation-based, so we do have to work hand in hand with the state in collection of our community numbers as well. So I wanted to give, like I said, a quick overview of what we did. And when I say that this is so informal, we started the MAT program a couple of years ago. Just, I was trying to think yesterday of how this came about. It really came about because we had two physicians that were champions in the field. They decided to go get their waiver, and they brought us along with it. And so when we were approached, of course, Mark and I were like, yes, we know this is a need in our community, and we wanted to provide this service. So we like I've said before, just jumped feet in. It's very intimidating. I've learned a lot, and then going forward in the future, especially with the 2 new grant opportunities available, we probably will amend our process a little bit better because, things learned and then also what we propose in our grant happens. I hope this can help some, just knowing that everyone will be different, in their community and stuff. But this is kind of just an example of what we've done. So we started, like I said, our 2 physicians that approached us that got their waivers. They wanted help, mostly because they couldn't do it on their own, but they were fully committed that the patient needed. They had the behavioral health component on it. They were full believers that, there's a medical side to this service, but the goal was, to technically get a receptive brain. And I'm coming from our physician that just, sent me she calls it Dr. Miller's experience with MAT, but a receptive brain to learn to, further learn those lifestyles to, change and be, productive in their communities. And they knew that, the medical side is only one component. So we did that. So in our system, we're thankful that 2 years ago, we got a new EHR system that had allowed us to be one patient, one chart. So whenever, so with that, like I said, none of the referrals. So patients can self-refer by phone or in person. So they contact our behavioral health office, or they can contact, primary care patient. And, our 2 physicians were located in primary care. So they just, come in and, identified, OUD, call specifically. And I can tell you what happened is we started this program and word of mouth spread, and that's how it doubled so fast. Is because, these patients come in and they get it and they tell their friend that needs it, or they tell their family member that's going through and needs it. So that's technically, so a lot of it started with self-referral. So self-referral, and then the providers in our health system can, if they have a patient that needs it, they can just submit a referral through our EHR system. And then we pull at behavioral health. We would get all the new requests, and and then we would evaluate. And really, our internal evaluation is this a new patient to behavioral health? If so, then we can get the screen. A new patient, then there's a couple of other procedures we like to do on new patients go through an intake, which covers the biopsychosocial. In our suicide, we want to make sure that the patient's, not in immediate crisis or self-harm. And then to start off, our goal is always that our physicians always wanted our patients to start off in behavioral health. So even if they presented at primary care, they would funnel them back to us, and that was kind of the start. And really, when I say when we first started this, we would start our staff meetings. We kept our patient log on Notepad. That's how just brief and just kind of, we just went, like I said, feet first in it. So patients told. We dedicated our LADC supervisor to this program, and so I believe she operated. She was at a lower FTE for our regular clinic, and so then her other job duties were to, be fully supporting our MAT program, and so the patient would be scheduled. Intake, the patient would be scheduled to BH counselor, and then she would assess and evaluate what the patient's needs are. And if she agreed that yes, the patient met criteria and for the MAT program, then she would forward back that information to our physicians saying, yes, I want so-and-so admitted to our MAT program. And then, next slide, then the physician would, always be with the physician's nurse, because this program was in addition to, like I said, what we're already doing in our outpatient clinic. As every other tribe high demand, few resources, and then the physicians that came on board for us, they this on top of their primary care load. So most of our coordination was with the physician's nurse. The nurses, our request to add a patient to their caseload for MAT, and then based on the approval, then they were admitted to the program. That the patient is kind of like a two-way thing. They stay in the behavioral health list for counseling individual, and then they go to a group that's specific for MAT patients and scheduled with the physician. So, physician. When we first did, we're located in Tahlequah, is our biggest behavioral health outpatient clinic, and it happens to be right across from our Hastings Hospital, our tribally owned hospital. So the location is very convenient. But, so our physicians, co-located, and we realized real quick that wasn't ideal. As these patients, their needs are a lot to say, to properly describe it. And it was best, so we learned real quick, it's best we need to be located in the same building. So when these patients came and saw their doctor, they seen a behavioral health therapist. It was like a one-stop shop, we called it. And it was so important that our counselor was laying eyes on these people, and because we know people are struggling with these addictions, and a lot of our patients were trying to maintain employment. They were trying to keep their kids, and we had to work around their schedules. And so physicians started coming to our behavioral health office, and what this meant is we had to up our medical supplies. So we had to make sure they had room so they could get vitals. And then if you see, like the physician runs all of these things prior to their appointment. Bills, PMP reports, requests, this all has to be done, or our physician would not see them. Because, the labs, are ran, they do a urine and blood. And when the blood comes back, it does give those levels of the MAT medication, because it's important to see that MAT medication is in their blood to ensure, diversion, or one way to ensure diversion. Then after the patient sees the physician, then they walk right back across the hospital to get their prescription. So that worked out. We don't dispense any meds or anything like that. So that was ideal. So challenges and barriers, we need more physicians with their waivers. And right now we are on a wait list because our 2 physicians that we had for our program left our health system about 6 months ago. Really left us, we are at a standstill right now. We do have our medical director has obtained his waiver and is kind of taking a few patients. And then one of the physicians does come back monthly, and she didn't have to do that. And so, but she is so committed to this, she decided to come back monthly. So she's trying to still cover her caseload, but the thing is we're not able to take new patients right now on the program. And so we're heavily seeking more physicians with waivers, and it's difficult. Depending on your agency and your health system, and two, we've really found that it's really hard to get education out there, that it's really not accepted in the medical field right now, and so we're really working on that, and we're hoping our grant really has some ideas to kind of push out a lot of education about that, and really garner some more support to expand our program. I can't express enough the need for the support for the program itself. Nursing, you have to have your registered nurses to do, like if your patient needs vaccinations, if they, to pull those labs, to pull all that stuff that the physician is not going to have time to do. That stuff needs to be done before the physician gets to the client. Extend to other clinics, we have 8 other health facilities across our 14 counties, and our goal is to somehow provide services in those. So we're proposing over the next couple years to expand in telehealth and mental health and stuff like that. Is always a barrier to our services. You're rural. we have limited public transportation, and so that's something we're always trying to use opportunities for transportation. Work schedules. I said a lot of our patients are employed, and that's one of the benefits of MAT is it keeps our patients that going or that have the OUD, it keeps them active in their community. It keeps them employed. You know, we have truck drivers, we have, you know, patients with small children. It keeps them involved instead of what, you know, the other side of addiction can do. So find yourself time to have altered schedule in your clinic. And right over, talk about the data.
Thanks so much, Joni. Sam, are you on?
Yes, I am on. Can you hear me okay?
Yes, thank you.
Everyone, my name is Tim Bradshaw, and I work with Joni in our prevention department. And what we do is prevention, of course, is trying to go upstream and trying to prevent folks from using prescription drugs or delayed onset and the progression of it. So we have with our team in the prevention department in collaboration with our clinic, we applied for or we received about 5 SAMHSA prevention grants, and 2 of those are on prescription drug, opioids. We have a teen suicide prevention grant and underage drinking, and we also have a new naloxone grant. We're providing Narcan out in the communities. So what today is the speakers that gave you some great information on the data, but like what I do is how to take all that information, how to put it into a grant application, and then how I use that to implement a program. So I would just talk about that a little bit. We have had success with the SAMHSA grants, and so I know that it can be different for everyone, but I just want to start with, for this, or pretty much any of the grants, SAMHSA needs that everyone needs. And so it's necessarily about showing need, though you need to complement it with data, but it's more about how can I take this funding and tell a story of your community and how that all works, how you're going to use that. So enough to state the problem. You need to paint the picture, give the insider's view of your community tribe. Basic data points that is your problem statement, define your population, and the support for your proposed approach. Next slide. So the way data, look at what's being consumed by our communities. There's specific indicators that can help you understand what's being consumed with tobacco and other drugs. And Kevin and Tyler and Brooke and Scott all talked about some of these data points. So we kind of categorized them. Then what is the consequence of consuming the prescription drugs? So there's specific issues associated with that, like the injuries, the hospitalizations, and the rest. And just using this or this outline layout, you can tell your story better. We also look at the social indicators, the conditions that influence the use, like where they access substances, their perception of risk, the attitudes and beliefs around a particular drug, if it's acceptable in a community or non-acceptable. Define your population, which is a major category in any of the grant applications, is you just want to talk about, the census data primarily, or if you have tribal-specific data on the population of your community. We look at the demographics, race, economic factors, employment rates, poverty, housing, things like that. That helps tell the story of your community. You want to add about your geographical area and any cultural uniqueness and or history of the target region or the population. Yes, next slide. You kind of tell your story using the different data of your target population. You're going to be selecting a proposed approach, rather it's MAT or something else, but SAMHSA likes to see based strategies or best practices. And there's a research out there for every component of this grant. I think this grant is to cover prevention, treatment, and recovery. So you want to find something to match that with, research that explains why your approach is expected to be effective to address the problem, and research that supports your approach is really appropriate for your target population, and historical outcomes using the approach with your target population. Basically what that means, a lot of times we have things going on in our tribe, in our communities that we need, and so you want to tell that story, that we had such a program like application, the project that Joni just went over, how we've accomplished certain things with it. So you want to make sure that you add that in your story. Yes, next slide. So just using data, you want to use the best data you can find. As much as possible, the local, county, or regional, or the state, or the tribal area, and compare it to national. But I say that a lot of times, as the speaker before me talked about, there's a lot of limitations with data, and it's best not be afraid of that, but just tell the story. If you have local that's lower than the county or the state, that's okay. It doesn't mean that you still don't have a problem. You just still tell the story, and a lot of times you can say this is a data gap that we have, but this funding will work with stakeholders to increase, more valid and reliable data as we work through the funding years. You want to get the most recent of the data that you're going to use. Example is the census data. Try to get the most updated. And I just spoke about comparing your data with the next level up. County level data, you want to get to your state or region and then tell your story about that. Next slide. For using data, use a mix of hard data, which a lot of the speakers talked about. That's our, what I call archive data, quantitative data. Hard data is the numbers and the facts, but you complement that with soft data, which is what's actually happening in the communities, and you can do that through focus groups, town hall meetings, or key informant interviews and different things like that. Because a lot of times, as you got heard, a lot of that data from these doesn't always tell the story of what's actually going on in the community, and we run into that a lot of times. If you want to cite your sources in application, to keep it simple, there'll be people reading these grants, so you want to put it in language that they can read easily. Add the citation and your chart, and again, make it easy for the reviewer to read it. Next slide. Some more on where to find data, and that I talked about in the beginning, and social indicators. You can look at BS to start with, a national survey on drug use and health, and then state surveys. Sounds like New Mexico has a really good state survey, and Oklahoma we do as well. It's called the Oklahoma Prevention Needs Assessment. It's down at the school and community level, and so it helps us get data on what students are doing. But we also own adult days that we have prevention specialists in all of our communities, and they start gathering data through different sampling techniques to get adult attitudes and beliefs towards how much is being consumed and other indicators. Again, influence data typically is health, social, or legal consequences from being consumed. So what happens to people when take too many opioids? Well, sometimes they may get it, and so you want to look at that data. They may, have a highway accident or something like that, but we also work with narcotics and our prescription monitoring program for prescription drugs to tell us how many people are having overdoses, fatal and non-fatal, and other issues. Population data, of course. So here's some examples of how we laid out our data in some grant applications. And see the big one in the middle. It's a couple of sources that actually Scott, I think, was talking about, is the Oklahoma State Department of Health Injury Prevention Service, intentional poisoning deaths. So we broke that down. We were able to get data for every county that we serve in the Cherokee Nation. That's also part of that is from the medical examiner. And some rates, we kind of tell the story through education and provide that. And then one below is just another example of the youth survey I was talking about, the Oklahoma Prevention Needs Assessment. So we just presented this data in an application prescription drug use for middle and high school students. As you can see, for this, the general means the rest of the state. We were able to get American Indian, Native American data pulled out of that, and you get difference. And so this kind of helps tell that story. And up there at the top is just an example of how we also write it in there where we reference the source. Low prevalent rates of 40% for past 30-day use among the general population and 41.8% among Native youth. Cherokee students get a higher at averages and then reference it. So those are just some examples of how we present our data in our applications. And there's a lot of different techniques and methods that you can use in gathering community level data. A lot of times that be going to the police department and going through their arrest records to see if it had prescription drugs on them, or doing different surveys and things like that. That is my last slide.
This is Joni again. The only thing I do want to add is I previously spoke about before the two grant applications that Tyler spoke about that our data from our child hospitals aren't reported to our other outside agencies. We actually do have access to that, thankfully, from our new electronic health record, and so we were able to pull data from patients, current patients, and patients seen to help us to help support our need for grant applications. And so we kind of did the same thing. We pulled based on diagnosis codes, and so we were able to pull that that data of patients we were actually serving, and then using it in combination with this community level data of showing both the need in our tribal health system and then the need in our communities.
Thank you, Tony, and thank you, Sam. That was wonderful. It's really tied all together of how it all fits together when you're representing your community and applying for these grants. So it looks like we have just a couple of minutes for questions, if there are any questions. Operator, would you be able to open the lines for questions?
To do that. To ask a question over the phone, please press *1, unmute your phone, and record your name clearly when prompted. Your name is required to introduce your question. If you need to withdraw your question, press *2. To ask a question over the phone, please press *1. It will take a few moments for questions to come through, so please stand by.
I'm waiting for questions as well. I was remiss at the beginning of the webinar in acknowledging our planning committee that we went through several months of planning. Amy Groom from CDC and Lisa Neal. Amy and I were at Tribal Consultation in Albuquerque in April when we started discussing opioids, and several of the tribal leaders expressed a desire to learn more about data as related to opioids to get prepared to be competitive for some of the funding announcements and also for strategic planning. So I just recognize both of them as well as Tracy Galandi and Raven Ross and Tamara James participated on some of our calls. And also Captain Watts from Oklahoma City Indian Health Service. So thank you for being on those planning calls. And if I missed anyone, I apologize, but I really appreciate the presenters as well. To have any questions?
No questions at this time, but again, as a reminder, to ask a question over the phone, please press *1.
I think that's a great job. They covered all the questions. If you're interested in getting copies of the slides, you can email me, and I shared that. Also, let me see if I've got there's my contact information as well. If you would like to reach out to me in any way, I can connect you to some of these resources or be able to help identify any other additional assistance.
There is a question.
Okay. Yeah.
The Epps, your line is open.
This is Kathy Epps from the National Institute on Drug Abuse, and this isn't a question so much as it's a quick announcement. Just wanted to make sure everyone on the phone is aware that we are in the process of developing a funding opportunity announcement that will provide research funding to support culturally relevant research built upon projects that are supported with the SAMHSA tribal opioid funding. So if anybody's interested in building a research project around the SAMHSA funding that is NIH supported, please be in touch with me. And email address, I'll say it quick, KETZ at NIH.gov. Thank you.
And thank you for your willingness to help us in preparation for this webinar. I really appreciate it. So it looks like the end of our time. I appreciate everyone that presented and everyone that participated in the webinar, and please let us know if we can be further assistance.
Today's conference. Thank you for participating. You may disconnect at this time. Speakers, please allow a moment of silence and stand by for your post.